everyone. My name is Elizabeth Manns, and I'd like to welcome you to the April 4th Coalition Show. This is the August 7th, 2023 edition of the show, and it is the 465th show that we have done since the closing of the North Adams Regional Hospital, and the 5th show that we have done since the announcement of the possible reopening of North Adams Hospital as a critical care access hospital. The April 4th Coalition's mission statement is, we are for workers' rights and collective bargaining rights and are against tax breaks for the rich corporations who ship our jobs overseas. We support all the articles of the Universal Declaration of Human Rights, but as is our custom, we put the emphasis on Article 23 and at the start of the show. And as we have a larger panel than normal, we're going to dish every single one of them out to someone. And I get number one. Number one, everyone has the right to work, to free choice of employment, to just and favorable conditions of work, and protection against unemployment.
Number two, everyone without any discrimination has the right to equal pay for equal work.
Number three, everyone who works has the right to just and favorable remuneration, ensuring for himself or herself and his family and her family an existence worthy of human dignity and supplemented, if necessary, by other means of social protection.
Number four, everyone has the right to form and join trade unions for the protection of his or her interests.
Okay, and as is our custom, we give a thank you to Michael Putnam, who is the program director for the community radio station WMNBLP 107.1, for airing the audio portion of our shows on Fridays at 6 p.m. And of course to the fabulous staff here at Northern Berkshire Community Television Corporation, Joanne Hurlbut, Nicole A. Brown, and David Fabiano for helping us produce the show. We could not do it without them. Dick, with the announcement of the possible reopening of North Adams Regional Hospital as a critical care access hospital, we've been putting the emphasis on healthcare for the past few weeks, and I think you had another video you wanted to show.
Right, last week, first of all, I just want to thank Michael and Susan and Rachel for joining us, and we're so happy because when we have this number of people, we really are a coalition, and it's important that all views get to be heard. We don't agree on every single issue, but it's great to hear the different voices because we all have had different experiences and different perspectives on the issue. And the issue of healthcare is what we're focusing on this week. Last week we showed two videos, one about the bill for Medicare for all in Massachusetts, a single payer system in Massachusetts, and then we also showed a video that talked about the faults within our healthcare system. And so we're going to show another video we couldn't fit in last week. It's a 10-minute video, and it's on the healthcare, the anatomy of the healthcare system throughout the world. So let's take a look at that.
Are you confused by the various healthcare systems in your country and around the world? You're not alone. This is the anatomy of healthcare. Dr. Jubal, MedSchoolInsiders.com. Perhaps you think healthcare is broken, and like many of us, you want change. But we must first understand healthcare before trying to fix it. In this three-part series, we'll explore the major healthcare models of the world, how the US fares in comparison, and what changes to make moving forward. Anytime you think about healthcare, whether abroad or here in the US, this is the blueprint that should come to your mind. At the root level, healthcare systems come down to four constituents: the government, the insurers, the patients, and the providers, which includes doctors, healthcare professionals, and hospitals. Depending on the healthcare system in consideration, the interaction and dynamic between these constituents vary. For example, sometimes the government is the insurer, which means it takes on the financial responsibility. Other times, the government is completely out of the picture, or it may play a regulatory role. There are four factors to consider between the four major healthcare models. The first factor is the number of sources of coverage, or financial support, that exist under the model. If there is one source of coverage, we call it a single payer model. And if there are several sources of coverage, we call it a multi-payer model. The second factor is the source of coverage itself. This could be the government in single payer models or private insurance companies in multi-payer models. The third factor is the source of funding. How are the government and insurance companies getting money to provide coverage? The last factor in consideration is the sector responsible for delivering care, the private sector or the public sector. This has to do with whether the hospitals are government owned or privately owned, and whether the doctors are government employed or privately employed. This has major implications for the government's regulatory power, autonomy of providers, and innovation. Each of the four major healthcare models sits on different points of the nationalization-privatization spectrum, with one end representing 100% nationalization, in which the government fully funds and delivers care, and the other end representing 100% privatization, in which the private sector fully funds and delivers care with no input from the government. Broadly speaking, nationalization is associated with greater accessibility to care, lower costs, and reduced administrative complexity, whereas privatization is associated with less regulation, greater freedom for physicians, and a more fertile ground for innovation. Out of the four global healthcare models, there are two single-payer models, one private-payer model, and one multi-payer model. The two single-payer models are the Beveridge model, found in Britain, and the National Health Insurance model, found in Canada. In both of these models, the government funds healthcare, but the primary difference between these models is in the delivery of care. In the Beveridge model, there is public delivery of care, which means that the physicians, hospitals, and clinics are all government-owned or part of the public sector. In the National Health Insurance model, there is private delivery of care, which means that hospitals, clinics, and physicians are all part of the private sector and have greater freedom to practice as they please without government input. There is often an expectation that greater government involvement translates to increased bureaucratic complexity, but that isn't necessarily true. In a single-payer system, there is no market competition, and with the government financing care, the costs that providers charge are kept low, benefits are standardized, and with no financial motives to deny claims and no concern for profit, the delivery of care is cheaper and often simpler to navigate. The frustrating complexity of insurance plans, claims processing, and claims disputing, factors that drive administrative expenses through the roof under the US healthcare system, are absent from the picture entirely. More on this in the next few videos. In both of these single-payer systems, there is universal coverage, which means that every citizen is financially backed by an insurer with little out-of-pocket cost to the citizen. The Beveridge model is often criticized for its potential risk of overutilization, as policymakers fear that free access would drive patients to demand unnecessary services, resulting in higher costs and taxes. That said, these systems have regulations and proactive prevention campaigns to circumvent these issues. To put this all into perspective, let's say your friend Harry, a British citizen, gets into a crazy car accident. In Britain, he'll be rushed to the hospital, government-owned, he'll be treated by physicians, government-employed, and he'll also walk out without any bill, because the government pays. This is public funding and public delivery. On the other hand, let's say your friend Justin gets into a crazy car accident in Canada. There, under the National Health Insurance model, he'll receive care at a privately owned hospital, and all his follow-up visits will take place with physicians of his choice in the private sector. Even though the government is footing the bill, it does not control how healthcare is delivered by the doctors, nor does it mandate its citizens to visit select providers. The doctors have greater freedom to practice, and generally, patients also have greater freedom to choose their providers. The third model is the out-of-pocket model. This model is essentially the absence of any formalized healthcare system, and we coin it a private payer model instead of a single payer or multi-payer model because citizens are forced to pay for care directly out of their pockets with no external coverage. Most nations are too poor to systematically provide mass medical care. Folks in such countries scramble to pay unaffordable bills in the face of emergencies. Medical care is a luxury reserved for the wealthy. The fourth and final model is the Bismarck model, which the German healthcare system is derived from. This model is the most privatized of the four models, with the government having the least involvement. At a surface level, it may resemble the US healthcare system because insurance is linked to one's employment, just as it is for most working Americans. The source of coverage is private insurance companies, and citizens dedicate a portion of their payroll tax to remain insured, with the delivery of care being mostly private. The theoretical Bismarck model is meant to provide universal coverage, but a criticism of the system is that even though universal coverage is the intent, it fails to financially cover those who are transitioning between jobs or are unemployed. And it's starkly different from the US for reasons we will visit soon. The final point to consider is the source of coverage for each of these healthcare models. Funding for the Beveridge and National Health Insurance model comes from income taxes. The government collects a tax from its citizens that ultimately enable government-based funding to support healthcare costs. In the Bismarck model, funding comes from a payroll deduction. Employers take a portion of their employee's salary and put it towards paying a premium to keep their employees enrolled under the health insurance plan. Note that universal coverage is an intended feature of all three of these models, and it can in fact be achieved in systems that are not single-payer models, despite what you may hear from policymakers. In fact, most countries with universal health insurance programs rely on multi-payer systems. Most of these countries use a hybrid of these four models implemented uniformly across the nation's borders. The United States is fundamentally different and more complicated. The major difference between other nations and the United States is the fact that here in the US, the healthcare system is a hodgepodge of systems. The US is one of few countries that provide provide care non-uniformly in 4 different ways depending on the patient population in consideration. Those 4 populations are veterans, citizens aged 65 or older, uninsured citizens, and working citizens with employer-sponsored health insurance. In the past, the term socialized medicine ignited fears of the US moving towards becoming a communist or socialist state. Today, the term ignites an expectation for poor medical outcomes, horrendous waiting lines, excessive taxation, and the erosion of free private enterprise. While the concept of socialized medicine makes some Americans uncomfortable, the reality is that a major portion of our healthcare system functions analogously to the British system, which is regarded as the closest example of socialized medicine in the world. We do this through the Veterans Health Administration. The VHA is a government-funded and government-managed vehicle that treats veterans at government-owned hospitals under the service of government-employed doctors. U.S. citizens over the age of 65 receive care in a national health insurance model-like fashion, as found in Canada. Manifesting in the form of Medicare, the government pays for the healthcare costs of the elderly, people under 65 with certain disabilities, and people of all ages with end-stage renal disease. Medicare is financed through tax revenue, a 2.9% dedicated payroll tax split evenly between employers and employees, and monthly beneficiary premiums. Medicare funds 70% of healthcare spending by the elderly, with the other 30% accounted for by out-of-pocket spending or supplementary private insurance. The key takeaway is that for this patient population, the government is publicly financing the cost of care, but the delivery of care remains in the hands of the private sector, just as in Canada. The third patient population is the uninsured. With 30 million Americans uninsured, our nation happens to be the only developed country that lacks a system of universal health coverage. The unfortunate reality is that medical emergencies strike when least expected, and in such scenarios, many Americans are forced to potentially face financial ruin in their effort to seek care. Expanding coverage remains one of our biggest healthcare challenges, but the politicization of care and the doctrine of American exceptionalism often prevents any meaningful conversation about healthcare reform from taking place. Veterans, citizens aged 65 and older, and the uninsured represent only a portion of the US population. For most US citizens, health insurance is provided in a Bismarck-like fashion, with insurance linked to one's employment status in a manner that is similar to the system in Germany. Again, the tenet of the Bismarck model is that employers and employees fund their own private health insurance through sickness funds financed by payroll deductions. The primary criticism of both the Bismarck model and the variant used in the United States is that coverage isn't necessarily granted to those who are between jobs or unable to work. For years, people have been asking whether it makes sense for health insurance to be linked to one's job. The pandemic has laid clear that in precise moments where friends and families and neighbors are most in need of care, they may also be least likely to have a job, and by extension, access to the very care they need. However, this variant is starkly different from the theoretical Bismarck model. Under the theoretical model, insurance companies are required to be non-profit, and every citizen is supposed to be covered. This is not the case in the United States, where our insurance companies have a history of marginalizing those with pre-existing conditions from being covered and are profit-driven. As our hospitals and providers bill insurers seeking reimbursement for services, insurers fiercely push back, denying claims. This insurer-provider battle drives billing-related administrative expenses soaring through the roof. Revisiting the nationalization-privatization spectrum, as we move from left to right, we see the Beveridge model implemented in Britain, followed by the national health insurance model implemented in Canada, and the Bismarck model found in Germany. Farthest to the right lies the United States healthcare system, which is the most privatized and market-driven, a feature that cultivates the nation's fertile ground for innovation. Each of these healthcare models has its own unique basket of pros and cons. Generally, those that are more privatized are driving innovation and enjoying greater autonomy, and those that are more government-regulated have a simpler delivery of care, less administrative complexity, and a population with greater accessibility to care. Join us in part 2 of the series to explore which country has the best healthcare system. Much love, and I'll see you guys there.
I'd like to commend the guy on being able to speak very, very fast to get all that in. Number 2 on that would be, I'm not sure I buy the innovation claim that if it's private, that if it's regulated by the government, innovation is out. After all, the U.S. government funds 90% of the research that's going on in this country. So I'm not sure I quite buy that. I'm pretty sure research goes on in Great Britain too, and whatnot.
Since I'm the one that gets kind of confused here, does that mean right now we have critical care access in North Adams, where people can stay over?
No, we don't have it now.
Not yet.
That's what I was afraid. It sounded good, except I didn't hear what I wanted.
Right. Well, at the August 3rd meeting, which is where I think you're leading us to, the regulations have changed that if they can get the hospital reopened, we would be able to have critical care access back up here. First step is to get the state to agree that we can reopen the hospital, because it has to be a new license.
But at first, this video that we watched covered what was going on in Canada, England, Germany, and the United States, in comparing the types of systems that we have. Like, and you were saying, like, Michael, you're a veteran, you go to a veterans hospital, there's doctors that are employed by the government.
To take
And
care.
a lot of people that are doctors in the private sector got their start in the Veterans Administration. Because you work for the Veterans Administration,
You get experience.
you get experience, and they probably forgive some of your loans
the
that you took
education.
out.
Right.
And so then
Then you move
to the private sector later.
But do we have that here?
No.
In North Adams,
Yeah.
at this time, we don't have inpatient beds.
Yeah.
But they're planning, and I'm pretty confident that they're gonna, in January, or near the first of the year, we'll have 25 inpatient beds. It might start out at 18, but they'll work their way up to 25. And the reimbursements like they talk about, rather than just private sector,
They'd also have the Medicare.
They had
full.
the
They'd have
Medicare
105 or 110.
101%, I think, 101% reimbursement for people on Medicare rather than 66%.
Correct.
Is it-
And then they just have to budget out for how long it takes to get
I'm a
paid by
VA,
Medicare.
I'm a veteran, and I get VA healthcare, right? But where's the nearest location for veterans healthcare?
You, Northampton,
Albany and
Pittsfield.
Bennington.
Bennington.
Bennington, and maybe Northampton.
Pittsfield?
I just
I
want
don't
people
think,
to
is there a
know.
veterans hospital? in-
Pittsfield.
Oh, not a hospital.
No.
They're
No,
not.
but there is one in Northampton.
Leeds,
Leeds and Northampton.
Northampton
Yeah.
and in Albany.
It was-
In
it's-
Bennington, I think there's a
Bennington is
smaller.
There might be
Small.
one up there.
Yeah.
I just want
there
people
is.
to know that this really is a distance for us to get the healthcare that we need.
Yep.
Right.
They're supposed to provide
Yeah,
transportation too
well,
for
we're
you.
seeing that one too.
Yeah, there
So
was,
these things up front, easy to get to and get it done. Every time there's an add-on, we're the victim. You know, I want people to understand, it sounds good.
well,
It always does.
that's what Berkshire Health System was saying, is that's why they're trying to move this hospital over, because they know it's most effective when people get treatment closer to home. More people, they use the treatments, they actually go to the hospital and use the services because it is close to home. Because there was a lot of cases where people would refuse treatment if they had to go to Pittsfield.
Which is your case. You don't want to travel far anymore.
Now, because usually if you need health care, you don't want to be riding a heck of a long ways, because you got to go and then you got to come back. And depending upon what your ailment is, and transportation problem, people driving, they can really hurt.
Right.
I just want you to understand, there's ways around all this. As a political people get up and off their butts and do it the right way to begin with, instead of waiting for it to fail and say, oh, we got to fix that now. If you know about it, do it.
Yeah, I have to ride to Springfield to see a cardiologist, and the thing is, I get a ride down and back. But I'm not as young as I used to be, and I get nervous. You know, well, I'm going to get dropped off and I'm going to get picked up, but gee whiz, I just got a cell phone and it is driving me crazy. And I said to myself, I got to go over it and over it because I want to make sure I get home and can take a message.
Right.
You know, I mean, I think the elderly, you know, have more problems with this, especially.
I really don't usually talk this much. I usually rather always talk, so that's it for me tonight. I guess.
Your help, you're
Your
good.
health is important. Everybody's is.
and the care the veterans are getting is just deplorable as far as I'm
That's what I was
concerned.
thinking.
And I do think, all I keep thinking is that phrase about what sticks in your craw. I want to know if any of this healthcare is going to unstick what's sticking in my craw. I'm listening to all that's being said and just watching those 4 different models, and I'm thinking, this is just disgraceful, unconscionable. The lack of any credible health care in the United States of America. And once again, this is the United States of America. Nobody should be without health care. And when you talk about financially taking care of that, I'm sorry, hey, you could take care of all this by cutting the Pentagon budget. Let's get real about the real needs that are going on in this country.
It's the type of thing of what are you defending us from?
Yes.
I think people would like to be defended from hunger. I think people would like to be defended from sickness and disease and
Homelessness.
death. Homelessness. So those kind of,
Yeah.
I mean,
If you're
Those
asking
are
the everyday
real
citizen,
life
yes,
needs.
They don't, I mean, unless you can really gin them up on the fear of the other or another country coming in and invading you, and that's fine, you should have some defense against that, but that doesn't mean you have to have the ability to kill the world 100 times over in order
right.
to defend
The amount of
yourself.
money that the United States spends on the defense budget, Ralph Nader always reminds us that it's the only department in the government that's never been audited.
Yeah, yeah.
It doesn't get audited. And when President Eisenhower left office, he warned us to beware of the military-industrial complex.
And now it's military, industrial, technological, AI complex.
Oh,
Yes,
AI.
all of these now.
Right.
Oh,
but
yes, it's
The
awful.
basics, though, the people, like in the Constitution, it said that to ensure domestic tranquility and provide for the common defense. So what we have to do as citizens is let our elected officials know what we want to be defended from. You know, what are,
Oh, I think they know what we want to be defended from, but this little thing keeps the ears
Right.
plugged sufficiently.
the amount of money we spend in defense.
Self-interest.
Would
It's-
help, would
Yeah.
help those of us, or people we know, to get health care. I mean, how much do you have to defend? Against what?
We, if you, the United States spends, their budget is I wish I had the numbers, but.
I'll
we-
bring them for the next show,
Yeah,
because I
there's-
have the military.
Right, we spend like almost double of what the next lowest country in their expenditures.
And people should know this too. Maybe should ask the politicians, since they always want to get back in office. Now, just maybe if they got together and really did something like this, it would help every American.
I bet you it would make it easier for them to win an election rather than going in the route they're going in now, which is the fear and emotion route, rather than the providing of services. And saying, hey, you're doing a great job, I want you back. Instead, they have to convince us.
Well, we have
be afraid.
entrenched politicians, and we also have a lot of people who could be voting, could be participating, who don't care because they think it doesn't matter. And there's reason to believe and understand why they think it doesn't matter. But
Oh,
that
yes.
makes it even more imperative that people get involved.
Oh, yes.
You know,
Many of the younger generation have checked out. They don't want to be
I
involved.
wonder why.
And, oh, I get why
Yeah.
they've checked out, believe
And
me.
those that, I mean, you're hearing it right now. We're having the discussion on the North Adams Hospital. All these people that are rah, 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 we're going to get critical care, critical access, you know. Where have they been these last 9 years? Where have they been since those 3 days stopping the closing of that hospital? And I think you said that one of the things was that it has to sustain itself. The North Adams Hospital and the community sustained that hospital for 129 years. It is a total community commitment that is required and has always been the pride of our hospital and healthcare system in North Adams and North County.
I can safely say one thing: when they shut the hospital down, I was the first one to get kicked off the property.
Yes, you
You could
were.
be very proud of that, Michael.
I missed it by about 20 minutes.
I was up there, and I tell you, I got
Oh, I just
I got
loved it.
kicked off. The man said, "Oh, Mike, I'm not kicking you off site." I told him, I said, "Paul," I said, "that is off site." I said, "You got the press right here." I said, "You got to be honest with these people. They're kicking me off site."
Yeah, yeah. And you were proud to do it that day.
Oh, you ain't get so stupid. I get a phone call from a buddy. "Mike, I can't believe what they're doing." What the hell are they doing? What, they can't do that. But they did it.
But they did it
And the
anyway.
problem here is anytime you hear this kind of garbage, the politician can do the job and they can solve the problem. If they tell you they can't, I think it's about time to get a different job.
Yeah.
And we're lucky, we had a senator that was fighting for us in
In the state legislature.
in the state legislature,
Benjamin Downing?
Ben.
Ben
The
Downey.
only elected official, and I'm going to say that again, the only elected official who tried to help save our hospital.
And then, you know, he's been replaced one time, and now another time, we have a new state senator, Paul Mark, and he's put forward legislation, and we talked about it in other shows, but it's worth repeating, that would require the state, if a hospital doesn't give the required 90-day notice of closing of a hospital or a clinic, and it's shown that services that they provide are needed for the community, that the state would step in and put
Receivership.
the hospital or the clinic in receivership until they could reorganize it and put it under new management. And the reason why I think that's fantastic is because we had a Governor Deval Patrick, who failed to act, whether it was conflict of interest or just he didn't care. He had the ability to declare a medical emergency and keep that hospital open, put it under state receivership until such time as they could find new people to manage that hospital.
And who knows, it might have still ended up being under
It
BHS's
could have-
wing, but it might have had government funding
Or
for a
it
while
could-
to keep it open.
Or like Cooley Dickinson, which is under Mass General now.
General.
It could have been that.
It could have been anything.
You know, you can't say anything? You're awfully quiet.
Well, usually I'm not. Usually I talk too much. I'm being a good girl today.
There you go. And this conversation is, and we're rolling around the table
No,
quite
honest,
fast.
go right ahead.
Well, we still have to go to the heart that our whole healthcare system, so-called healthcare system,
Oh, I
has to be systemically, structurally cleaned up, top to bottom and bottom to top. I mean, this is just not acceptable, what is happening in the United States of America.
Right, and I hope Massachusetts passes that Medicare for all.
Bill.
And when they say Medicare for all, not that Medicare for all that you still have to pay 30% in co-pays or whatever, a Medicare for all with increased benefits, with dental, vision, you know, that we pay through our taxes and through payroll tax paid by the businesses to provide for a healthy community in Massachusetts where everyone is covered, everyone in,
100%,
nobody out.
Rich.
Nobody out, one system.
Yeah.
And I think that, you know, that's what they're advocating at the national level, Medicare for all with increased benefits. But right now, if we can do it in Massachusetts,
We can
maybe
be, we
be
can
the
be,
first.
we can
Be the
show
model.
the country again, just like we showed them with what we now call Romney Care, our
Well,
current vision.
If people
Which
don't
only
understand,
leaves about 5% out, but.
people don't understand Medicare for all, it's the same as universal health care for
It is.
all, isn't it?
It's
The
like they
two
have in
words are
Canada.
interchangeable
It's
for
like-
our audience.
It's like the movie that we've watched just a few minutes ago, or the video that we watched, it's the Canadian model, because
Yeah.
the hospitals and the doctors would remain private, but the
Government would pay.
government would pay. But we're
And look
down to
at that,
10
we're
seconds.
down to 10 seconds, so.
Power
I know
to
a
the
nurse.
people.
People.
Oh,
Mike?
well, we-
Power to the people.
Power
Only
to the people.
people.
And we'll see you next week.
If the people get united, they can't be beat.
That's right.
But we all gotta get together as a group. No me. No me.
There's power in the factory, power in the land, power in the hand of the worker. But it all amounts to nothing if together we don't stand. There is power in our union. Now the lessons of the past were all learned with workers' blood. Mistakes of the bosses we must pay for. From the cities and the farmlands to trenches